So welcome to the second webinar of Data Saves Lives initiative. And it's been 3 months since we had the first one. And during that time, a lot of things happened. So we have changed and reconsidered our normals. So we thought for the second webinar of Data Saves Lives, it could be a good idea to discuss a little bit about COVID-19 and beyond. Just a topic we know a lot of webinars are covering right now, but we thought it would be very important for Data Saves Lives also to bring to the attention of our community and how actually what's the role of government in tackling their populations and health, and how can we support as Data Saves Lives. So I'm going to cut it short and pass the floor to my colleague Jess, who's going to be moderating the session today. I will be also here if you have any questions or any technical issues. I'll be at the background. So thank you, Jess, the floor is yours.
Thank you, Gøsta. So yes, over the next half hour, you'll be hearing from our expert panel in 3 successive 10-minute presentations. I'll introduce them all individually before their presentations in greater detail, but just so you know who we've got here as your expert panel, we've got Professor Mark Lawler of Queen's University Belfast and co-chair of the European Cancer Organisation's Special Focus Network on COVID-19 and Cancer. We've got Dr. Claire Walton, Head of Research and Drug Access at the Multiple Sclerosis International Federation, and Alistair Kent, President of EGAN, the Patients Network for Medical Research and Health, and former Executive Director of Genetic Alliance UK, a position he held for 25 years. So a couple of housekeeping pieces. Please do keep your microphones on mute, and we'll be holding all questions until after the 3 keynote speakers have presented in the second half of the webinar. But you can still ask them in the Q&A box so that you don't forget, and we'll make sure that we ask them in the moderated discussion. As you'll have seen upon entering, the meeting is being recorded, and this is so we can put the presentations live on the Data Saves Lives website after the event, and include with a key highlight summary. So for your friends and colleagues who've missed it, that's where they can find it afterwards. Our desired outcomes for the session are that you can better understand the potential role of governments in tracking their potential population's health. As Gøsta mentioned, better understand the potential influence and role of patient organisations in supporting large-scale health data initiatives in respect to their nation's populations, and also feel inspired to undertake more data-driven activities, whether it's anything from community surveys to inform your own organisation's efforts, or to actually influence the practice of others, so government policy, health service delivery, and so on. So, without further ado, I'll introduce our first speaker. So Professor Mark Lawler has an international reputation in cancer research, it's safe to say, receiving the prestigious 2018 European Health Award, among other accolades for his contribution to the field that have been influential at both national in the UK and international levels. His academic research focuses on developing a molecular understanding of cancer to improve patient care, including through precision medicine approaches. As Associate Director of Health Data Research Wales, Northern Ireland, he also has a keen interest in health data research, which is why he's here today in his role as co-chair of the European Cancer Organisation's Special Focus Network on COVID-19 and Cancer. If you haven't already seen his blog on the importance of real-time data on the Data Saves Lives website, please do check it out. It's a neat summary of what he's just about to present. And again, something to forward on to colleagues. So Mark, I hand over the floor to you.
Thank you very much indeed, Jess, and thank you everybody for beaming in today. Obviously, there's a lot of different challenges in relation to different webcasts, etc. So really delighted that you joined us today, and hopefully we'll stimulate you and make you think a little bit about why data saves lives. Next slide. So what I thought I'd do is really talk a little bit about how we've used data, and particularly real-time data, in influencing cancer policy during COVID-19. Next. For me, this whole story starts with a personal aspect. My uncle died on the 29th of March of this year of a COVID-related illness. And Edward Dodoliak, who's a colleague of mine from Croatia, from the University of Split, reached out to me to commiserate with me on my loss, but he also said the following. He said that in Croatia, people were starting to fear a COVID-19 diagnosis more than a cancer diagnosis. And that really worried me. Because anecdotally in the UK, we'd heard similar stories, but there was really no data to either back up that assertion or refute it. So in DataCan, which is the UK's health data research hub for cancer, we decided to start a collaboration, a data-driven collaboration with University College London to really try and find data that would either back up that assertion in relation to people fearing a COVID-19 diagnosis more than cancer. Next slide. And the work that we did was in two parts. Next. One was to look at real-time data, and we feel this is really important, looking at real-time data from hospital trusts across the United Kingdom. And we decided to look at two measures that are routinely captured by hospitals. So something that we could easily look at and then infer from. The first was 2-week waiting time, or sometimes called red flag referrals. This is the early warning system that we use in the UK for suspicion of cancer. So here what we're really looking at is the diagnostic pathway. And then we also looked at chemotherapy attendances and changes in those, which is a good proxy of the health of the cancer treatment pathway. And so looking at these two and looking at weekly data from hospital trusts across the United Kingdom, what we found was, next slide, was that we really saw precipitous drop in relation to both 2-week wait referrals and chemotherapy. If you just concentrate on the green sort of yellow shading in these two graphs here, you can see there a very significant drop, and no matter which hospital trust you look at across the United Kingdom, particularly so in relation to 2-week wait, so that referral pathway, but also in relation to chemotherapy. Next slide, please. And so if we look at this and put some numbers on it, and we now are starting to get very used to numbers because we see them every day, no matter where we are in the world. So we saw a median of a 70% drop in relation to 2-week waiting time referrals and 41% in relation to chemotherapy. But what does that really mean? So what does that mean to the individual? Next slide, please. What that means to me, accessing that health service, is that 7 out of 10 people who had a suspicion of cancer were not getting referred to a cancer specialist service. And it also means that 4 out of 10 cancer patients were not getting access to their chemotherapy. This data really worried us. So straight away, sorry, just go back to the previous slide. So straight away, we reached out to the government, to the academia, to the NHS to show this data. So we actually provided this data before we submitted it for publication. And what we really reached out was to the 4 chief medical officers and the National Director for Cancer, because we thought it was really important to see this data and the potential impact it was going to have in relation to cancer services, but most importantly, cancer patients in the UK. Next slide. So why did we use real-time data? Well, hopefully this slide will show you. So on the left-hand graph, what I'm showing you is looking at on the 9th of June, what we're doing is we're looking to see what does the national data for 2-week wait look like in England. And when you look at that graph, it doesn't really show you much differences. It's more or less the same. It's more or less a straight line with a few minor variations. Why is that? The reason for that is, although we looked at this data on the 9th of June, if you actually look at the graph itself, the data is from March. So the data is over 3 months old. If we contrast that with the next slide, where we actually look at the real-time data we had collected, you can see it's much more granular. You're getting weekly readouts, but also you're actually seeing that precipitous drop that we saw in relation to 2-week wait and then the start of a recovery. So this is why you need real-time data. And one of the things we're doing now is setting up across the United Kingdom, so England and the devolved nations, I'm based in Belfast in Northern Ireland, a real-time data network that will not only help us in relation to COVID, but will also help us to much more accurately look at the position in relation to cancer across the United Kingdom. Next slide, please. The other thing we did was we looked across the whole cancer services, across the pathway, and you can see here, just very briefly, we see presentational delay, so screening essentially stopped, referrals dropped significantly, diagnosis dropped significantly, ways in which we could do diagnosis, for example, endoscopy, which we use for a number of cancers, including bowel cancer, dropped over 76, 80%. So again, real challenges in relation to our cancer services. and real challenges for either individuals who have a suspicion of cancer or patients who are being treated for cancer. And the other area is cancer research. So 30% of clinical trials disrupted overall. In some regions, that was as high as 80%. Discovery research, translational research was also shut down. And those of you who have followed the story will know that Cancer Research UK have had significant challenges, funding challenges mainly, in relation to cancer research and supporting cancer research across the UK. Next slide, please. And so this really worried us. And the other thing we said was, well, can we look at this in relation to what's the potential excess mortality? So what I've shown you so far is all based on data in the here and now. This is looking at modeling data, looking at excess mortality in patients with cancer, but also using that real-time data that I showed you to inform our model. But this is a model, so just putting that caveat in front of you to make sure that you're aware of that. But even still, between 7 and nearly 18,000 potential excess deaths in people with cancer due to the effects of the pandemic. Next slide, please. So again, very worrying. And one of the things that really, sort of makes me wake up at night in a sweat is the fact that we've done so well in relation to cancer research across the United Kingdom and its impact in relation to cancer care. So what we've seen is 5-year anticipated survival across the United Kingdom has gone up over the last decade. However, what we're starting to see is some of the data that we've shown here and that other people have contributed to this effort. This has been very much a pan-UK effort. What we're seeing is that for certain cancers, particularly colorectal cancer, we could be set back nearly a decade in terms of our 5-year anticipated survival rates. Next slide, please. So what do you do with this data? Well, one of the things we did was present it to the European Cancer Organization. We felt this was not specifically a UK problem, and a lot of interest, similar scenarios, drops may be less profound, and that's led to us setting up a European Cancer Organization special network on COVID-19 and cancer, which myself and Miriam Kluwer are delighted to co-chair, and we're going to come out with a report in relation to the state of play in Europe at the European Cancer Organization Cancer Summit in November. We also provided the evidence base into WHO Europe's 70th Regional Committee meeting in Geneva, which we attended virtually. And again, you can see that data as well if you're interested in it. Next slide, please. So what is the impact of this? One of the things that's been really important is our way of sharing it with stakeholders, with the NHS, with the 4 chief medical officers, with the cancer director, National Cancer Director for England, feeding into SAGE, which we feel contributed to the decision to start restoring cancer services. You can see there obviously a lot of media attention, which is important, because one of the messages that we want to get across is, if you are somebody who, for example, feels they have suspicious symptoms that may be cancer, we really want to encourage you to attend your GP and then be referred on to your GP if that is necessary in relation to confirming or refuting a cancer diagnosis. So that's really important message to get across to citizens and to patients. And the other thing is that very much cancer has become one of the first priorities of recovery because of the effect and the impact of COVID-19 has had in relation to cancer. Next slide, please. What I just want to emphasize is that it's important that this data is out there and that people are able to see that data. It's important that governments provide this type of data so people can actually look at it. But it's also important that, as well as following the science, as we've been advised that that's what we're doing in the UK in relation to the response to COVID, you also need to follow the data. The other thing I would emphasize is getting back to pre-COVID-19 levels itself is not enough in relation to either diagnosis or treatment. That new normal can't be the same as the old normal. We may have to be actually acting at 130% of capacity to really make a difference in terms of reversing some of the scenarios that I've suggested may happen if we don't act quickly. Next slide, please. The other thing is you can use data not only to highlight the issue, but also to be part of the solution. And this is really important. And this is work that was led by Claire Turnbull, and we were fortunate enough to be involved in it as well, looking particularly in colorectal cancer. And what we found here is that looking at ways in which we can reduce that risk of significant excess deaths and loss of life years by using fecal immunochemical testing. So normally a test we use in screening. Here what we've looked at is how can you actually use it in the context of symptomatic patients and use it actually to triage who really needs colonoscopy in a scenario where you don't have full capacity of colonoscopy. And so that's helped us to prioritize the use of tests, for example, colonoscopy, but also try and reduce that presentational and diagnostic delay that I mentioned earlier in relation to the data that we've used. It is only a short-term solution, so we really need to get back to 100%, or as I say, probably 130% colonoscopy, but it is a way of showing you how the data can be used to actually help in the recovery, as well as highlighting what the issue is. So just to end, one of the things I really want to emphasize, next slide is, please, given that data saves lives is what we're talking about here, the power of data to improve cancer care is really effective. And one of the things we're trying to emphasize both to the government, but also to the NHS is, don't let cancer become the forgotten sea in the fight against COVID-19. Thank you very much for your attention.
Thanks so much, Mark. We've discussed that data before, so I'm less shocked hearing it the second time, but nonetheless, it paints a pretty scary picture. And we've actually already had one question come in, which again, we'll address at the end, but just a reminder to everyone to share their questions, which is talking about how we get that balance right to protect ourselves and our hospitals against COVID-19, but not let our care slip in other areas. So that's something we'll return to. And obviously, anyone else has any questions for Mark, then of course use the chat box to send them to us or the Q&A, and we'll address those later, because I think there's a lot to explore and break down, but conscious that we hear from all of our three speakers first, as a lot of the presentations are complementary in terms of their content. So our next speaker is Dr. Claire Walton, who is Head of Research and Drug Access at the Multiple Sclerosis International Federation, acting on behalf of 48 MS patient organisation members from around the world. She recently led the development of global COVID-19 advice for people with MS and established a rapid global data sharing initiative for COVID-19 and MS, the learnings of which we're just about to hear about. Now I could spend half her presentation time speaking about her credentials, but to summarise, prior to her current role, Claire spent the last decade working in UK-based medical research charities as the science communicator and research advisor. She also has a PhD in neuroscience from the Rockefeller University in NYC. And I'm delighted to hand over to Claire to talk about, from a patient organisation perspective, what's being done around COVID-19 and how data saves lives.
Thanks, Jess. Very delighted to be here to talk to you about what we've done in the last, I guess, 6 months. So Jess just summarised the organisation I work for, Multiple Sclerosis International Federation. I'll call us MSIF because it's much less of a mouthful. We're a global network of 48 organisations with links to many more around the world. Next slide, please. Sorry, my voice today. So we first got involved in COVID data sharing really because it was very much driven by questions we were receiving from our patient community. Questions both to us as an international organisation, but also to many of our members. Right at the start of the pandemic, people were nervous about what it meant for them as people with MS. Were they at greater risk of catching COVID? Were they at greater risk of more severe symptoms? Were the drugs that they were taking putting them at greater risk? So right at the start, we gathered together an international group of MS neurologists and researchers to try to come up with some advice that we could give to our patients and our patient organisations to help. I think at the time, this was right at the beginning of March, there were only 3 documented cases of COVID-19 in people with MS, all in Italy, and all 3 in the hospital at the time. So we produced some advice. It was definitely on the more cautious side because we were largely drawing on these 3 cases and also on clinical expertise of what we assumed might happen to people given the drugs they were taking for their MS. There was a very clear message in that first consensus meeting, which was we really needed data. We needed to start activating people to collect data, and we needed to share it rapidly so that we could start addressing people's questions in a much more evidence-based way. Next slide, please. So I reached out to Professor Lisbeth Peters, who is a data scientist at the University of Hasselt and also the chair of the MS Data Alliance. I reached out to her to ask her what we could do on a quick scale to try to help the community get together and start collecting and sharing data. So we very rapidly set up the COVID-19 and MS Data Sharing Initiative, which launched at the end of March, so within a couple of weeks of the first COVID advice meeting to launching the initiative took a couple of weeks only. And these are some of the partners who came on board right from the start to help us with developing how we were going to manage the data and analyze the data. And also Quamenta, who are a cloud-based data platform, kindly provided the services for us to develop a global platform. We had 3 objectives with our initiative. The first one was to scale up collection of data from people with MS and developing COVID. We decided right from the start that we would do this not by setting up a new study, but by actually reaching out to existing MS registries and cohorts. We knew that everyone wanted to do something. Everyone was starting to think about collecting the data. So we thought the most effective way would be to try to harmonize these efforts and build on the existing infrastructure rather than set up something new. So we reached out to many of our networks and got them on board and first agreed a core set of variables that we would try to encourage all the registers to be collecting. We managed to do that within 48 hours. So by the end of March, we'd launched the initiative and we'd all agreed on a core set of variables that we could collect. And we then activated the registries to go and start doing the work. Another key advantage of working this way was that it made the ethical approval much easier because each registry was responsible for amending their ethics, and we could then just get essential ethics for the sharing and the aggregation process, which, because we have used de-identified anonymous data, was much easier. MSIF also, at this point, launched a communications campaign to try to activate our communities to take part in the initiative. We reached out to our patient organizations, but also our clinical networks. The second objective was very much around speed. So we wanted to trigger increased data collection and sharing, but fast, because we really wanted to be able to start providing answers to our patients during the pandemic. So that meant we adopted many pragmatic solutions to the way we did it, but it also meant we developed a really inclusive data sharing architecture. So we encourage both patient-reported and clinician-reported data to come into the initiative. And I'll talk through as well. We also allowed people to share data from their own registries, but also to directly input into the central platform, so that as many different groups around the world could take part, rather than kind of being very saying, we'll only take this one kind of data and it has to come into us this way, which would have required a lot more work in the different countries and I think would have probably slowed us down. There are, of course, some negatives to have including so many different kinds of data that we can talk about a bit later. And then our third objective was to act as a stimulus to steer ongoing research. So yes, we wanted to be fast and we wanted to get some insights during the pandemic, but we also wanted to do this in a way that the MS community could learn. We wanted to create and test some new data sharing architectures and build new collaborative networks, especially with areas of the world that we haven't really been able to work with before, such as Latin America. Next slide, please. This map just shows you our current data partners. So we have 20 data collection partners from North and South America, Europe and Australasia, all collecting and sharing data with us. There are obviously quite a few areas of the world not indicated on here because they don't have existing registries and cohorts. And so we encourage these areas of the world to report directly into our global platform. Next slide, please. And this shows the quite complicated data architecture that was the creation of Lisbeth Peters at the MS Data Alliance. So just to try to explain this to you a little bit. There's 3 ways that data can come into our project. Direct entry into the platform, either by clinicians or by patients. And patients can enter it in Spanish, in French, or in English. Patient registries and cohorts can then directly share de-identified anonymous patient level data with us directly, or we then, some of the registries we were working with, this wasn't possible, even sharing de-identified data, it was still not in compliance with their data privacy regulations. So we then introduced a third mechanism which is often known as federated data sharing, where the same analyses are run across multiple cohorts, and then they can just share their counts with us, and we can aggregate their counts into one big data pool. Next slide, please. So this summarizes the current data set we have. We've amassed records on nearly 9,000 people with MS from 82 different countries. And you can see that there's quite a difference between cases that are reported by patients and cases that are reported by clinicians, with many more clinician-reported cases being suspected or confirmed positive for COVID, and also having more serious symptoms. So many more of the clinician-reported are hospitalized and requiring ICU compared to the patient-reported. And this is what we expected, but actually it was more striking than we expected to see that there's quite a bias between how the data is reported. So for that reason, moving forward, we have kept the 2 kinds of data very separate in our analysis. We haven't mixed them. The variables that we collected are listed on the left of the slide. And so we've just presented the first results from this initiative at the International MS Virtual 2020 conference, and we've submitted for publication. And the key findings are in this blue box. So it was actually really reassuring for our community to see that people with MS have similar rates of developing COVID and dying from COVID-19 to the general population. There are some predictors of a more severe COVID-19 infection. Some of these are what we see in the general population, so age and also male sex, but some are specific to MS, so the type of MS and the level of disability a person has also can predict a more severe COVID case requiring hospitalization and ICU admission and death. And importantly, one class of MS therapy that's regularly used to treat MS, a disease-modifying therapy, is also associated with more severe COVID outcomes. Next slide, please. So outcomes and learnings, our first 2 objectives we feel are definitely met. We've been able to scale up data collection within our community, and we've rapidly shared and amassed some insight that has been able to inform how we are helping our patients during the pandemic. So although we haven't published the results yet, as Jess mentioned at the start, MSIF have been producing global COVID advice for people with MS that has been regularly updated. So as the data was coming together and being analysed, that was presented to our clinical advice group, and it has been incorporated into the global advice. So people know that there is a risk for one of the groups of MS therapies. And we have heard, we just met last week to update the advice again, and we've had clinicians from places like Lebanon telling us that there's nothing else for clinicians treating MS patients in their countries than this advice, and so they really are using it, and it's informing the discussions that patients are having with their doctors about treatments during the pandemic. There were some other positives coming out of this work. So new registries and studies have been established in areas of the world where they didn't exist before. So interestingly, North America and Canada actually don't have an MS registry, but they've created a joint one called CoV-MS for the COVID pandemic. And they aligned with our data dictionary so that they could harmonize with the global effort. And then some of our patient organizations in Latin America began collecting patient data for the first time from their patient communities. And that was very much triggered by this. They were able to learn from some of the other members in our kind of consortium, and we were able to give them advice on ethics and the steps they needed to go through to begin to set themselves up to do this. The other really significant point was that global data sharing was essential to spot this drug association. So there's been several national studies published that haven't been able to see this. I should have said at the beginning, there are 17 disease-modifying therapies approved for MS. So if you think about the numbers of people with MS who also get COVID who are on a given drug, it's actually quite small within each country. So we needed the power of global data sharing to be able to see these signals. We feel that we've really achieved unparalleled collaboration in such a short time, and a big facilitator was the existing global networks that both MSIF have, but also MS Data Alliance, and we were able to motivate them very quickly with a clear shared mission. Objective 3, to continue and underpin future research, is still ongoing. One thing we've definitely learned is that working as fast as we did has compromised some of the long-term sustainability of the project. We haven't really designed the infrastructure in a way that would facilitate solving questions down the line. So it may be that we don't use the data sharing initiative architecture that we have moving forward, but what we will definitely use moving forward is the collaboration and the networks that we've built to continue working together on global questions. That's it from me. Thank you.
Thanks so much, Claire. I mean, that is an absolutely fascinating project. And to your point, the collaborative success that you've seen in such a short amount of time is testament, obviously, to the power of the network, but also the power of trust that patients have in terms of wanting to contribute to those registries so quickly, which does tie me on nicely to Alistair's presentation, which is on building trust through patients and patient organisations around sharing and using health data. If you have questions for Claire that you want to type out now that they're fresh, please do use the Q&A box, and we'll return to them in 10 minutes time after Alistair's presentation. Thanks, Alistair. Oh, great. Gosh, sorry. Forgive me, I was about to hand over to Alistair without his much better introduction, just to give you a little background to his history. So Alistair was the Executive Director of Genetic Alliance UK, which is the UK alliance of over 200 patient support groups for patients and families with rare and genetic disorders, a position he held for almost 25 years. In that capacity, he was actively engaged in developing policy and practice in biomedical research and service development that would both reflect and respect the needs and expectations of patients and families affected by serious and life-limiting rare diseases at a national, European and international level. He's been a member of countless committees and working groups, and was made Order of the British Empire, so OBE, for services to healthcare in 2011. Since retiring from Genetic Alliance UK, Alistair has continued to work on behalf of patients and families affected by rare and genetic diseases. He's currently co-chair of the UK Rare Disease Policy Board at the Department of Health and Social Care, and chair of the Rare Diseases Advisory Group for NHS England, as well as being president of EGAN, the Patients Network for Medical Research and Health, who he is representing today. So apologies, Alistair, those are quite the credentials, and it would have been a shame to miss those. So now I hand over to you properly.
Great, well, thank you very much, Jessica, and good morning or good afternoon or good evening, depending on where you are listening to this. Quite a number of the points that I might have made have already been made, so I will try and be as brief as possible in order to allow the maximum amount of time for discussion and for questions. But I think just to emphasize where I'm coming from, I think if we look at the area of engaging with patients, with patient organizations, in order to build the opportunity for data to be collected and shared, we have a huge opportunity there, but it's not a blind trust that will be invested in the process by patient organizations. By and large, patients are very keen to share their data, both for the purposes of improving clinical management of their conditions, but also for the for supporting the advance in understanding, for creating the opportunity to undertake research, and for ensuring that valuable resources are not wasted by undertaking projects that will reveal stuff that is known already elsewhere to someone else. But patient organizations, in order to feel confident in the process, need to understand, in a sense, who is asking for this data. What is the purpose for which the data is being collected? Are they confident that the people, the institutions who are seeking their data are competent and have got the capacity to use that data in a scientifically and clinically valid way? Who else will have the chance to investigate that data? Who will see information about them? And to what other uses might that data be put? Now, for researchers, for people building registries, patient organizations can provide a fantastic insight and a fantastic opportunity to engage with the community of people who have the condition which interests them. But of course, not all patient organizations are equally well developed, equally sophisticated in terms of their ability to support and engage with academic or commercial partners such as pharmaceutical or biotechnology companies. And it's important when engaging with a patient organization that researchers, that industry and the public sector are able to make an appropriately scaled demand on that patient organization. Many patient organizations exist on precious few resources, and although it's often remarkable what they can achieve with those resources, if you make an unrealistic demand, then you're likely not to be able to create a sustainable relationship. And I think it's hugely important to realize that patient organizations have been, that many of them have had their fingers burnt by requests for them to share information about their members, about the people who they know of with the condition, by organizations which have basically done a scoop and run approach and not invested in that long term, the sustainability of the relationship, and with a clear message about not only what information they would like to see, what data they would like to see collected and used, but also how the results, the outcomes of that will be fed back into the patient community in order to advance insight, understanding, opportunities for managing the condition. Now, the building of a long-term relationship is something which has been going on for well, many years in some instances, but has been recently expanded with the growing recognition of the importance of patient-generated information about conditions and about the possibilities that creates for undertaking effective research and development. You know, if you think about it, a patient may spend whatever 5% of their time in consultation with their doctors, but 95% of their life is carried on outside the clinical context. And much of the information that is generated in that 95% of the time has previously been inaccessible to clinicians and researchers because they haven't been able to engage with the patient community and allow for that input from the end users, the people who are affected. Now, that acknowledgement of the importance of patient-led information has been growing and developing, but unfortunately, a number of problems have arisen as a result of the pandemic, which may potentially put that trust-based relationship, that partnership between the academics, the clinicians, between industry and with the patient organisation, and ultimately with the patients under some threat. Obviously, for patients living with rare diseases, the onset of the pandemic has created a huge amount of uncertainty. Many conditions, for many conditions, there is very little information about the vulnerability of those affected to the pandemic, and many with severe or life-limiting conditions have been put into situations where they are required to shield. However, the process by which people who have been notified of their vulnerability has been less than perfect, shall we say, in many cases, leaving individual clinicians uncertain as to how to advise their patients whether or not they need to shield, whether or not they need to take extra special measures to avoid the risks of contracting the pandemic. And coming out of shielding, again, the advice, the information, the support that's been available to families has also been variable in terms of its quality and in terms of its accuracy. And unfortunately, that has put a strain on or a potential strain on the relationship between clinicians and their patients. Even without the damage to service provision that Mark Lawler talked about for those with pre-existing conditions, as a result of the diversion of resources into fighting the pandemic and the disruption to other forms of clinical care and to research. So the trusting relationship is in some respects under threat. You compound that with the noted failures in track and trace and contacting systems that have been reported not just in the UK but in many jurisdictions around the world, whereby patients have been left in the dark. Should they isolate? Should they not? Should they? Can they go out? Can they go on with their lives? There have been numerous reports of patients not being contacted for days. There have been reports of data being lost or failed to upload, all of which shakes the confidence of the patient community in the ability of governments, of healthcare systems, actually to provide them with timely support and with accurate information about their risk situation and the actions they should take about it to mitigate those risks. So if patients don't have confidence that any data that they are going to be, as it were, uploading into the system will be properly manipulated and used in an effective and efficient and a timely manner, then that rocks their willingness, their confidence in the ability of the government, of the healthcare system, to manage the data properly and preserve their confidentiality, to not allow data to be misused. And then when you get stories such as the one in the UK press yesterday, that the police might be allowed access to data generated by the track and trace apps that are being developed, and particularly for certain sections of the community, which may not have a very positive relationship with the forces of law and order, because of issues like institutional racism, because of issues like the disproportionate use of DNA sampling for criminal and forensic purposes, then the potential willingness of patients, of families, to see their data uploaded and shared, whether for COVID management purposes or whether for other purposes which they might have endorsed in the past but maybe more suspicious about in the future, is well, it must remain open to question. So how do we get around this? I think we need to be totally transparent about what data we collect, what we're going to use it for, who's going to have access to it, and for what purposes will they have access to it. There needs to be honesty about the limitations that what we can do with the data. The more data we have, the more information we can generate, the more opportunities we can create to intervene and modify. But in the early stages, we must be careful not to overpromise in terms of operationability of the data, or people will lose trust. They will not want to continue to make the effort to engage. And we need also to be able to demonstrate that we're in it for the long haul, that this isn't just a quick in and out, give me your data, I will do something really interesting with it, which will benefit me, but it's unclear what it will do for you. So if we can be transparent, if we can be honest, if we can be in it for the long term, and if we can work in a spirit of partnership rather than a top-down hoovering up of data type approach, then I think patients and patient organizations will be more than willing to collaborate and to generate the data that will enable the research, that will produce the knowledge and create the disease-modifying interventions that we're all so desperate to see. So thank you.
Thank you, Alistair. I think a lot of the points around trust are critical and really demonstrate why Claire and the MSIF's project was such a success, because they had that trust. They're very clear with the objectives from the outset, and actually those collaborations you can't beat. There's always going to be some skepticism, I think, around how people will be using data. So actually knowing that its purpose is to provide information around, shielding, how is that condition performing with COVID, because there is this gap potentially where we're letting people with chronic diseases shield indefinitely because we simply don't have that data, and that's not fair to do. COVID-19 is already challenging enough. Now, I realise we've only got 10 minutes left of the formal webinar. If you do have questions that we don't get to, then I believe our expert panel will be happy to answer them in writing offline, which we can coordinate with them. But some of the questions I might just address now. And obviously, please do send more through on the chat and Q&A. Nothing will get lost, even if it's not answered live. So one of our questions was to say thank you, Professor Lawler, for your excellent first presentation, and the data are truly concerning. In your early slide where you show the precipitous drop in the 2-week presentation data, there was a drop in 2019. Can you explain the reason for this? Because if it's not to do with COVID-19, obviously we'll have data from different years that reflects different things.
No, absolutely. So we looked right back to January 2018, actually, in relation to the data. The reason for that drop in 2019 is Christmas. So that's the Christmas week period in December. So you do see a drop, but it comes straight back up again as we go into the first week of January. Whereas obviously the drop that we saw in relation to COVID-19 was very precipitous, but also lasted much longer in terms of that recovery. So if you like, that's also a way of seeing that data is accurate, because we do see that in relation to that drop in relation to referrals in that time just around Christmas.
Great, thanks, Mark. And another question on your presentation, which I suppose speaks to a lot of the content here, which is what guidance is there or potentially can be created for governments in terms of how we prioritise safety and capacity for COVID-19 versus conditions like cancer in order to get this balance right? Because some of it sounds slightly like a lose-lose situation.
I think the nuanced approach is important, and I think if you think back to March, your approach, partially because we didn't have the data to tell us what to do, wasn't that nuanced. It was a sort of a one-size-fits-all approach. And I think what the data is starting to show us is, yes, there are certain people who need to be shielded. There are other scenarios where actually allowing treatment or diagnosis to take place makes more sense. So it's using the data to really drive that more nuanced approach, and that's certainly what we're recommending as we enter into the second wave of the COVID-19 pandemic. It's really using that data to see where are the key pressure points, where are the pinch points, and then how do we relieve those pinch points, but also how do we make sure that we protect patients.
Thanks, Mark. And yeah, I think those pinch points are really important because, and actually, Claire, you mentioned this too, that the data you collected speedily might not be fit for purpose to answer long-term questions, but obviously has been incredibly valuable for these specific objectives. So I think there's a challenge when it comes to data projects and how they're perceived across the community, that they probably have to be faultlessly robust and therefore slow moving and more time consuming to analyse. But both obviously Claire and Mark, you've presented projects that show the power of rapid real-time data collection. Do you think, Claire, you could speak a little more to this for those patient organisations that might see health data projects as outside of their capabilities? How you might be able to reassure them that it is possible to do?
Yeah, we definitely see from some of our members that data collection and all of the privacy regulations is really daunting. But I think all levels of data that you can collect is useful. We've got some really great examples from our MS community where, simple community-based surveys of their populations have been impactful. So the UK MS Society did kind of a needs survey of people with MS, and they were able to, by asking the right questions, so obviously you've got to think about what the purpose is and the end use of the data. So they asked questions around frequency of routine visits, and they were able to show that it makes sense, but they were able to demonstrate that more regular visits meant greater uptake of treatments, of disease-modifying treatments. And then they then use that data to get the NICE guidelines, which informs clinical practice in the UK, to then propose regular yearly visits, which weren't happening before. So I think you can have big impact with lots of different kinds of data. It doesn't need to be, all singing, all dancing, really robust, long-term registry data, although they're very useful too. But I think about what you want to do and what you want to achieve with that data, and then you can design a project that will meet the needs. Ours was a very short-term project. There were loads of people have come to us and said, can we ask this of your data? Can we ask that of your data? And the answer is no, because we didn't get the right permissions, we didn't collect the right data. And, yes, in a way that's a shame, but if we'd have gone slowly and done it differently, and we wouldn't have been able to do what we've done, which is really give people some useful information to inform their decisions now. So I think don't be daunted, think at different levels of what you want to achieve. And then the key for me, reach out to academics and data experts, because they are really valuable to help you navigate the regulations.
Absolutely. Thanks, Claire. We also have another question, which actually, Alistair, I might field your way, which is to talk about, in general terms, attitudes to data sharing. Should we be thinking differently about patient attitudes from those of the public, or should we consider them as a whole? And in which case, do we need different approaches? Because here we have been very focused on targeting communities living with particular conditions rather than the citizen population.
I think, by and large, patients, people living with the lived experience of a severe and life-limiting condition, are very keen to see their clinicians talking to each other, that data is shared, because that way they will be more likely to experience a better quality of care and a better, more coordinated experience of service delivery. Also, I think people with the lived experience of serious disease tend to be, as a general rule, more willing to participate in clinical development, in clinical trials, in discovery research, and so on, because despite the progress that we've made in recent years, the vast majority of diseases still are incredibly intractable, and many of them are incurable. There is very little that can be done to modify the trajectory of the condition. So for many patients, the opportunity to participate in research is a benefit for them, in that they get to experience a greater insight into what is known about their condition. And also that opportunity helps to create a feeling of, to some extent at least, taking charge of your life, rather than being, as it were, the blind victim of this malevolent condition that has, struck you from out of the blue. And I think that is part of maintaining the mental health of the patient and of the family as well. Feeling that they're in control to the extent that is possible. And I think that relationship is likely to be sustained if the focus is on engaging with the patient, with the family, to make sure that the data that is collected is data that people need to know, rather than data that it is nice to know. If the patient is the involuntary partner in this process, nobody chooses to have a serious life-limiting condition. So therefore, to make the most powerful use of the willingness of patients to contribute to research, to better clinical management, focus on the important issues and the things that you will absolutely be likely to make a difference, rather than some of the rather more peripheral things that might be really interesting, but less likely to produce life-changing alterations.
I think that's the key. We've heard that a lot in other forums outside of this discussion today, that just because you can measure something doesn't mean that you should. So let's make sure that we are focused. It comes back to that transparency piece, and particularly now that governments are getting involved so heavily with public health data collection through things like COVID tracking apps. It's also important that they learn how to communicate this well, which is probably a place where patient organisations can play a key role, because it's a role that patient groups have been used to playing with other stakeholders, not necessarily governments on this scale, but to advise how to engage and I suppose what to engage on with the community. So that wraps up our hour. Thank you so much again to our expert panelists for your wonderful presentations. I think it's given us all a lot of food for thought, which hopefully we can explore in other forums for Data Saves Lives. Do follow us on Twitter and Instagram for more content. You can also visit the website, where we'll be hosting an edited version of this for the presentations on the website, and some key highlights.